Well, hello, I'm Matthew Kaufman. I'm one of the plastic surgeons here at Houston Methodist. And today we'll be discussing robotics and plastic surgery, and I have no financial disclosures. So why is a plastic surgeon here? That's a great question. I think it's better to understand what do plastic surgeons do, because I think a lot of people don't understand that. I think from a PR standpoint, a lot of people think plastic surgeons are simply cosmetic surgeons, and I think the reality is a lot of plastic surgery involves reconstruction, and that is a majority, if not the entirety of my practice. Reconstructive surgery is the management of complex wounds and defects following cancer extirpation and traumatic injuries. This involves breast reconstruction, pelvic and abdominal reconstruction, upper and lower extremity reconstruction, head and neck reconstruction, lymphatic surgery, peripheral nerve surgery. So wide breadth of surgery in patients of all ages, anatomy throughout the body, and we work with nearly every surgical specialty in the hospital. And the way we accomplish these goals are through performing flaps, which is repurposing tissue. They're kind of in broad terms, pedicled flaps, which is tissue still connected to its blood vessel leash that is rotated about a pivot point, versus a free tissue transplantation or a free flap, which involves microsurgery where the tissue has its intrinsic blood supply, it's mobilized, divided from its source vessel, and then moved remotely to a different recipient site where the vessels are reconnected with hand-sewn anastomoses under the microscope, and these vessels usually range about 1 to 3 millimeters in diameter. So again, the goals of reconstructive surgery are to restore the form and function and provide well-vascularized tissue to facilitate healing while minimizing donor site morbidity, which again is what we strive to do. Often our surgeries are not minimally invasive, but we try to have less donor site morbidity to accomplish our goals. So again, what do we have to do with robotic surgery? These are the FDA indications in the specialties that involve robotic surgery, with an asterisk with breast surgery oncology, currently ongoing trials to have this FDA approved. But it's a wide scope of surgeons, and again, we work regularly with all of these surgical disciplines. So when we see the robot in the room and they are doing a complex, minimally invasive robotic surgery, and then they hand the patient off because they need a reconstruction, we then do things very open. So we see this very advanced technology and then our conventional ways, and work is being done to sort of marry these ideas together to see how can we play into this technology. The advantages of robotic surgery, I'm sure it's been discussed multiple times, but again, for the patients, decreased donor site morbidity, less pain, faster recovery, shorter length of stay in the hospital, and overall better outcomes. For the surgeon, improved precision, tremor control, and motion scaling, improved visualization, so high resolution 3D imaging modalities, even computer augmented reality can be safer because of this. Helps us get access to confined spaces, not unlike what Dr. Kim was talking about earlier, getting into the pelvis and the head and neck, and overall improved ergonomics. And this picture is obviously not of me, but most days I'm in the operating room, you will find me looking exactly like this. Turned up sideways with I have loops on, a headlight, and this can seriously impact the longevity of a surgeon. I'm still, like to think I'm still pretty young, but recent from our literature shows up to 70% of plastic surgeons have musculoskeletal complaints, and again, using the robot can hopefully add time to the to the surgeon's career. So what's been described as far as robotics and plastic surgery, which again is an emerging field. I think overall, the applications that have been described do not completely remove the open surgical aspect of plastic surgery, but rather augment our skill set already. So working to develop and harvest flaps in a less invasive manner, as well as augment our technical skills to improve outcomes. So abdominal wall, pelvic reconstruction, breast reconstruction, lymphatic surgery, and again, head and neck reconstruction, which again, we won't discuss since it's already been covered so well. So beginning with abdominal and pelvic wall reconstruction, again, the pelvis and the abdomen are the site of many robotic procedures by our gynecologic, urologic, and colorectal surgery colleagues. Often when a large tumor is resected, the patient is left with a large dead space, as we call it, or a potential space. And this is often the setting of previous neoadjuvant radiation therapy. the plastic surgeons are called on to recruit tissue in the form of flaps to bring in non-radiated, well-vascularized tissue to obliterate these potential spaces. And this has been shown to improve healing outcomes, decrease infection rate, and wound healing complications. It's important to note the anatomy of the abdominal wall. So you can see on the right, the strength layer of the abdominal wall, as I'm sure has been covered above the arcuate line, which exists sort of transversely just below the umbilicus. You have your anterior and posterior rectus sheaths, which house your rectus abdominis muscle. But as you go below the arcuate line, it's the strength layer is predominantly the anterior rectus sheath. So we take this into account when we plan our surgery. So on the left is a schematic of a abdominal perineal resection for a low rectal tumor, and the surgeons today will perform partly external surgery to remove the perineum, as well as robotic surgery. And again, this surgery involves resecting the sigmoid colon, part of the rectum, the anus, the pelvic floor, so it creates a large potential space. And the sort of gold standard workhorse procedure to obliterate this space from a reconstructive standpoint is to use the abdominal tissue, and this is a VRAM flap, a vertical rectus abdominis myocutaneous flap, which is to say that it's tissue that skin and fat that overlies the rectus abdominis muscle, and this is dissected. The muscle is removed from its superior connections, removed by making an incision through the anterior rectus sheath into the abdomen and rotating this tissue into the pelvis, where the skin can sometimes serve for posterior wall vaginal reconstruction, as well as well-vascularized tissue to obliterate this space. In this procedure, though, if the patient has already benefited from the previously explained benefits of a robotic procedure for shorter hospitals, say less invasive, less painful, now we've converted into this large open procedure which they have to heal from, and we've effectively weakened their abdominal wall further. So work has been done to try to perform robotic rectus abdominis flaps. So again, the advantage of this, and this is where instead of making an external incision, performing a laparotomy, dissecting through the anterior rectus sheath, all of the flap harvest is done intra-abdominally. The ports are placed, the flap is mobilized while being preserved off its inferior blood supply, and the muscle itself is used to fill that dead space as it's rotated, and it can also serve to cover either colonic anastomoses or urologic anastomoses as well that have been subjected to radiation. So it avoids disruption of the anterior rectus sheath. You don't need a large laparotomy incision. It's possibly better for males as they have a narrower pelvis, and again, bringing in this thick subcutaneous tissue, which you can see in the bottom right picture, delivering that through the pelvis, that can cause it to be delaminated and create problems. And again, that's hair-bearing skin that you may not want to have there. And overall, preserves the benefit of why they had a robotic procedure to begin with. So you're not really increasing the OR time, the length of stay, and the complication rates. Plus you have a facile, well-experienced robotic surgeon there who can proctor you as you begin this process, as well as advocate for you to improve patient outcomes through this mechanism. So moving on to breast reconstruction. So breast reconstruction is the restoration of form following a mastectomy. Overall, large classifications are autologous and implant-based reconstruction with the goal of replacing the volume and in some cases the skin. So autologous reconstruction, it's the use of the patient's own redundant tissue, and again, often this is used from their lower abdomen. If the patient wants to avoid having implants placed, it allows for more modification and shaping for the patient, so it can be a little more unique as opposed to the kind of cookie cutter breast implants that we have available to us from a sizing standpoint. And often autologous tissue is needed following radiation, as there are much higher rates of implant exposures, infections with just implant-based reconstruction in an irradiated mastectomy pocket. So along the course of development of breast reconstruction using the abdomen, this is sort of the time frame, and a lot of this is before my time, but we began with pedicled trams, which again, not dissimilar from bringing that tissue into the pelvis that we mentioned earlier. This tissue is kept on its blood vessel leash from the rectus abdominis muscle, and it is all brought in concert up to the chest where it is inset. From that was developed the free tram, where again, the muscle and the vessels that nourish that muscle and the overlying skin and fat are dissected, clipped, transferred up to the chest, where blood flow is reestablished under the microscope using microsurgery. From there, work is continuing continually being done to minimize abdominal donor site morbidity. So taking less muscle in the form of a muscle-sparing tram, or the gold standard currently is the deep inferior epigastric perforator flap, where the flap, the skin and fat are isolated on just the piercing blood vessels through the rectus sheath. They are traced through the rectus sheath into the rectus abdominis muscle, where the larger perfusing deep inferior epigastric pedicle is dissected back to its source vessel. And this is closed, and the patient, we transfer the tissue up to the chest and we close the abdomen. The reason why we err towards doing surgeries with less abdominal donor site morbidity is because of the complications. These are often underreported, but when you disrupt more of the abdominal wall, the strength layer, the muscle itself, and the nerves involved, it stands to reason you have a higher chance of developing weakness, bulges, or even true hernias. So these are things that we try to avoid. Specific to the anatomy, as we mentioned, the perforator, you can see on the left the CTA demonstrating the perforator piercing the anterior rectus sheath and nourishing the overlying skin and fat. And the other view demonstrating the course of this vessel as it perforates through the rectus abdominis muscle through its intramuscular course, and then caudal to that as it travels deep to the rectus abdominis muscle back to its source. The more we have to gain length on our pedicle is to allow for more ability to have larger vessels to perform microvascular anastomoses, and accordingly we have to provide larger exposure, which can contribute to larger abdominal morbidity. Similarly, when you perform this dissection from superficial to deep, you have to negotiate motor nerves that encase the pedicle as well as the perforating vessels, and often these are sacrificed. So even if you are able to spare the muscle itself, you are inherently denervating it, which makes it less functional. Thus became the idea to harvest these flaps robotically, where the initial portion of the procedure is the same. The skin incisions are the same, the dissection to the perforating vessels is the same. The dissection is done exteriorly from top down, so to speak, through the rectus abdominis fascia into the rectus for the course of the muscle, and then once the perforator meets the rest of the pedicle, the robot is brought in and docked. And here are a couple of videos that hopefully work, but it kind of shows the robotic dissection of the pedicle vessel intra-abdominally, which involves less abdominal morbidity as the muscle is not being disrupted, which again avoids the crossing nerves and again allows for us to get increased pedicle length. So here you see the pedicle has been dissected from the underside of the rectus abdominis muscle. It's been clipped and divided intra-abdominally. Then the arms are removed, and the flap with its long pedicle are delivered through a much smaller fascial incision. And again, this provides additional length as well as vessel caliber to help facilitate microvascular anastomoses when this is transferred to the chest and connected. Let's see why the next slide is not going. Okay. And again, this just shows what the advantage is. On the left shows a traditional deep flap. That's the donor site. Even if the muscle is not taken per se, it's by definition spread apart. We've got a large fascial defect. And on the right, you see that caption A demonstrates a very small fascial defect, but a very long pedicle. And this illustration demonstrates what's the benefit of doing that. You essentially allow yourself to only have a fascial disruption that measures the length of the intramuscular course of your pedicle. You do not need to extend that and have a larger fascial defect that extends inferiorly to achieve the same pedicle length. And this is important, especially when we talked previously about the arcuate line, where we divide that anterior rectus sheath, it becomes much weaker and you have a higher chance of abdominal wall morbidity. Going on, again, augmenting our armamentarium, the latissimus dorsi is a flap that can be harvested. It's an expendable muscle, and we use that for a variety of different reasons, whether it's breast reconstruction in a pedicled fashion, upper extremity reconstruction, as well as distant free flap reconstruction for scalp, lower extremity. And again, traditionally, we have to make a large incision to allow us to harvest this very large muscle, which is seen on the left. With the robot, this does not change as far as what we're doing and what we can purpose this muscle for, but it allows us to accomplish this feat through a much smaller incision, which again can benefit the patient greatly. Going on lymphedema, this is a condition that involves dysfunction of your lymphatic channels that is often seen in breast cancer following lymph node dissections and radiation, but it can be seen in a variety of situations. But it involves the dysfunction of the lymphatic draining vessels, which contribute to increased arm circumference or leg circumference, whatever it be, as well as eventually fibrosis and complications involving infection. So physiological surgical options that are being employed are vascularized lymph node transfers, so harvesting the omentum, an organ inside the abdomen that is very rich with lymphatic tissue that is lymphangiogenic, can be harvested robotically and transferred to the site where it's needed, as well as immediate lymphatic repair or lymphovenous bypass where the lymphatic channels, the flow is directed towards a nearby vein. The challenge with this is a technical challenge. Again, this involves super microsurgery, which is an anastomosis of vessels even smaller than previously described, again on the order of 0.3 to 0.8 millimeters, so considerably smaller and more technically demanding. And with that in mind, work has been done for dedicated surgical robots for microsurgery. So the Samani surgical system, here demonstrated with the operator manipulating the hand pieces and it translating to the arm, is a dedicated microsurgical robot, and again, benefiting from the tremor reduction, motion scaling, and allows for completion of a more technically demanding, much smaller vessel. Whether it be a lymphatic or even a perforator to perforator, which again can contribute to less morbidity. You can see in the bottom drawing, and again, this is probably exaggerated since it is from their website, but there is inherent tremor when you're operating on this scale, and if this adjunct can help minimize the tremor and improve the technical ability of surgeons to perform this, this may become more ubiquitous in practice. Now, with this microscope, you often have to employ a visual mechanism, so again, an exoscope, a 3D exoscope that's demonstrated here, and the benefit of that, you can, from an ergonomic standpoint, visualize this better, but also incorporate ICG for augmented visualization, whether it be lymphatics or vessels, so that can improve our outcomes. And again, this is a video that may be in the near future. So here's the surgery taking place on the monitor. You see the folks by the patient and the robot in place, and they're acting as assistant when the surgeon is over here sitting down, performing the operation, looking at the screen with his 3D glasses on. So this may be where things are headed. The challenges with robotics and plastic surgery is how do we adopt this technology as a field? I think it's a different infrastructure with respect to other systems and other services that have incorporated robots. Right now, we don't have any FDA approval to do any of these things per se. So how do we establish that? How do we establish a training program? The learning curve with respect to visual feedback that we need as opposed to our standard haptic feedback with experienced surgeons have gained over time, as well as patient selection. There's fixed resources, and are these robots even available? As they may be in a different case, they may be being used, so how do we use our resources appropriately? There's also associated costs with adoption of this technology, the 3D exoscopes, the robot systems, and understanding that as this technology evolves, when do we want to jump in and become part of it? Do we wait for the advancements to be exactly what we want, or do we start using it and see what the benefits are, understanding that things are constantly changing and we need to change with it? So where do I see things going in the future? I hope to establish a training program here at Houston Methodist. I think phasing implementation and collaboration with our other surgeons is the ideal starting point. And I think with more experience with this, it will drive more innovation. I think one potential option is the continuum of breast cancer surgery, where their mastectomy is performed robotically, their reconstruction is performed robotically, and lymphatic channels that may be disrupted as part of an axillary dissection are also repaired robotically. We can couple imaging modalities and hopefully get improved outcomes as well, working with technology to try to work on a smaller scale to get less morbidity. And again, working on microsurgery friendly instrumentation. I think machine learning, again, capturing this data through video, which we, generally speaking, in plastic surgery do not do a great job of capturing video, open things up for using this data to create technology that can perform autonomous anastomoses, such as the smart tissue anastomosis robot that's been described for bowel repair. So I do think there's a lot of future direction. We just need to get going. So thank you very much for your time, and I appreciate it. And this is my email if you have any questions, and look forward to hearing from you.
Well, thank you, Matt. Very stimulating, but you got some challenges. And one of the comments said, odd that the plastic surgeons are the guys making the biggest incisions now. And I think that's going to be a challenge for you. I actually think the analogy between vascular and you are very similar. And I'm going to tell another story we told this morning. I got called up to an operating room one day because they had bleeding from the pelvis in the blood vessel. And I went in there to help them. That's my job. But the robot was docked in the pelvis. I said, you want me to take the robot out and sew this? No, I think you can do it with the robot. And I said, I can't. And I got dismissed. And the surgeon took care of the bleeding. I think the challenge for plastic surgeons, you're going to be in the same boat. If you get called in by the GI surgeon who's done the abdominal perineal resection through a couple of little incisions in the perineal incision, and you want to make an incision this long to reconstruct, you're going to get replaced. And so the challenge is, how do you stay engaged? And I know you've been thinking about this. And Dr. Kim, do you have any questions that you want to ask or comments?
How widely spread is the use of robotics in the harvesting of the deep flap and the lat flap currently?
So I would say it's overall definitely not a large portion of people's practices. I think there are some centers, MD Anderson, for example, Cleveland Clinic, where their path to becoming part of this has been a little bit different. They've been either grandfathered in or have a general surgery background and have adopted this early, and they're sort of the promoters of this initially. Again, and there are other programs, but is this widely adopted? No, but I think as we still strive to minimize our donor site morbidity, if this is something that can augment our existing practices, I think it's something very important to engage in and become part of before, like you mentioned, we're on the other side of it.
Yeah, I mean, so again, the other analogy is that I trained in general surgery, okay? But there's also a different training pathway now in vascular surgery, same as you've got. You go straight into vascular surgery, you don't do any laparoscopic surgery. The exposure to general surgery is minimal. Well, now it's going to be a challenge to take that cohort and retrofit them to be able to do this. And so I presume the same paradigm is taking place in plastic surgery.
And again, that is the challenge, and I think the widely available surgical robot, the Da Vinci, it's an interesting position where they control kind of the credentialing, the pathway through their training courses, which I find to be interesting from a technology application, because again, we would use it, we're not going to be performing prostatectomies with this robot, we're going to be using it to augment what we do. And I think trying to incorporate that safely, no one wants to do this surgery safer than we do, and I think that's the point. So how do we really incorporate that and integrate that into our training program?
So as you were talking, I was thinking, I mean, there's not a whole lot of difference between the deep flap and taking down the internal mammary artery. One's in the chest and one's in the abdomen, but there are very established pathways in cardiac surgery for dissecting out the left internal mammary artery and using it, not necessarily sewing the anastomosis, but the takedown. And so I think one of the challenges you're going to have to figure out, kind of like we did, is that we were fortunate that we kept peritoneal dialysis catheters in our armamentarium. There was an easy, low risk, where you can get your teams up to speed and you can get experience with it. I think you're going to have to try and figure out the same thing, because the challenge is you're usually the second wave surgeon that comes in, and they're not particularly going to want your residents to be trained on the abdominal perineal resection or whatever the reconstruction needs to be.
Yeah, I mean, you bring up an excellent point. I think what one avenue would be, we do abdominal wall reconstruction, so ventral hernias, that is an indication. We do have overlap with that. We do that, and can we incorporate that as part of essentially a stepping stone to before we get to tedious dissection? I think the instrumentation needs to follow, as well as from a precision standpoint, microvascular clips. The handling of the instrumentation is on a macro scale as opposed to a micro scale. But I do think there are challenges, and where do we see ourselves? Because again, you don't want to start with the hardest case that you can imagine. You want to do something safe and reproducible before you And then once you have that under your belt, you can expand your indications, what you do, and offer that technology to your patients.
Are you going to get your reconstruction done by the plastic surgeons if they have to come in and make a big incision?
That is a
loaded
great
question.
point. I mean, for the lay population as well, and patients coming in to see us, if they see different advertisements, one as minimally invasive versus not, then that will certainly play a role in their decision making and expectations as well. So,
Do most plastic surgeons have laparoscopic credentials? Could you, in other words, can you put a port in somebody's abdomen in an institution like this based upon your credentialing pathway? Or is that going to be another
That's a
battle?
great question. I would say probably not. I would have to look, but again, that is not something that we do regularly because again, short of this, and there have been some description of harvesting these flaps using endoscopes or even laparoscopically, but again, the advantages conferred by the robot sort of outweigh those. Is that something that we come in to from training and get credentials in the hospital? I would say no.
Yeah, so again, this is what I think the single port robot, as I say, we started intracavity. Now we're thinking about how we can do extremity stuff. You're more in kind of the extremity stuff. I mean, latissimus dorsi, I've actually shared the patents with endoscopic vein harvest by working with a plastic surgeon at Emory.
Okay.
And because we watched minimally invasive latissimus dorsi harvest. And Monty Eves was his name, worked with John Bostwick, and we developed this thing together. And so it seems to me like latissimus dorsi harvest would be a pretty good place to start.
Absolutely. I think there are, again, what is the sort of low-hanging fruit? What's the easiest place to enter with, again, understanding that you're going to have collaboration from other surgeons, proctoring, going about things safely, but what is something that can offer an advantage to the patient? I think that's a great example. And again, muscle harvest, it doesn't relegate the entire operation to a robotic procedure, but it does augment those areas and, again, making it less invasive.
So two different parts. The big dissection. That's in the intuitive realm. Correct. And then there's the reconstructive part, joining small blood vessels together. What's the scoop in the plastic surgery world about MMI? I mean, it doesn't do dissection. It's purely designed to join blood vessels together.
So I would say, and again, this is my opinion, a lot of these, especially when you're talking about scale on the lymphatic level, which is super microsurgery, which is a lot more technically demanding, I think the concept would be to more or less democratize and allow a good microsurgeon to become a great super microsurgeon. That would be their argument, but you could also argue the investment related with that and what are the applications as they develop. Now, I would say this is a very new technology. Do they have the, whether it's the IP or the ability to create instruments that allow for dissection? I think a lot of that remains to be seen. But I think it's a very interesting technology that can augment and allow us to implement a robust lymphatic program. I think having access to that could be a complete game changer. And again, not only with lymphatic vessels, but as we mentioned with a deep flap, we still have to dissect out our pedicle length to get sufficient length as well as caliber. If we had something that was more allowed for a little bit more latitude with respect to your technique and facilitated performing small vessel anastomosis, perforated or perforator flap is the probably even less morbid approach to this. And again, can this technology help with this? I mean, it seems like it has the potential, but remains to be seen.
Let's democratize it even further. One of the arguments I brought up at our national meeting was, look, if you can adjust my tremor and scales a millimeter vessel up to make it look like the aorta, can the aortic surgeon sew it?
Well, that's what they always, I mean, that's what they always told us is when you're doing microsurgery, you want to make microsurgery macrosurgery. Yeah. So how can you make something that is more complex? How do you simplify things? And it's taking it back to the source vessel, something of appropriate scale. And I think if this can augment that, but just like all these technologies, I'm sure when the initial the Da Vinci was brought out, where it was and where it is has changed along the way. And I think being someone who is leading medicine, I think it's important to be in the driver's seat and kind of controlling where things go.